Welcome and thank you for joining us today. This telehealth presentation is brought to you by the Now New Mexico Quality Improvement Initiative that focuses on optimizing care for neonates at risk for opiate withdrawal syndrome. This 12-part curriculum is designed to give providers, nurses, care coordinators, and community members content-specific training and education with opportunities for care consultations around this focus. And today we have three wonderful presenters. We have Dr. Heather Pratt-Chavez. She's an associate professor of pediatrics in the Department of Pediatrics with UNM School of Medicine, where she's been since August 2010. We have Karen Longnecker, a clinical social worker with the FOCUS program, whose area of practice is infant mental health and behavioral health integration in a medical setting. And we also have Peggy MacLean, assistant professor in pediatrics and psychiatry, whose area of expertise is early childhood and infant mental health. Welcome, everyone.
So for today's talk, I wanted to have some experts in the field come and help us to do some practical applications of using infant mental health as a way to care for these vulnerable families. So that's why I asked Karen and Peggy to be with us today. So we're going to do two talks in this series, and the first one will be on non-pharmacologic interventions for babies and moms who are dealing with neonatal opiate withdrawal syndrome. And so Peggy's going to lead this first session.
Well, thank you for having me. Today what I'll talk about is some of the ways that we provide care for little ones who have neonatal opiate withdrawal syndrome, particularly around non-pharmacological care. And so we're really going to look at key areas of intervention. The first one is how can we actually reduce environmental stimulation for these little ones, and how can we support their self-regulation. We're also going to look at both promoting and protecting sleep in little ones, which is really important, as well as how can we support them with feeding. We're also going to look at how can we individualize their care, how can we understand who this little one is and kind of tailor our care to supporting them. And the last two areas we're going to look at is how do we actually create a supportive environment in the hospital setting that can really encourage both the infant's care and also promote the parent-child relationship. And so we're gonna focus on all these areas, and we're gonna identify interventions that can be applied in your practice. Little things that you can do that can really support infants who have this as well as their families. So when we're talking about interventions, we're really trying to focus on three key areas. And that is, first, the baby's regulatory capacity. So what we know of infants who have prenatal substance exposure is that they are more likely to have difficulties in terms of their regulatory capacity and their self-regulation. So most of the interventions that we're going to talk about today are really trying to target helping them in this area. The other piece we're going to look at is how do we have interventions that actually support the parent's regulatory capacity as well. So we know with substance use difficulties, one of the things that it's associated with is regulatory difficulty in the adult as well. So emotion regulation difficulties. And so again, we're keeping those things in mind as we're looking at areas of intervention. And the last piece is we want to make sure that every intervention we have with the family is actually supporting the parent-child attachment. We know that supporting attachment between parents and infants is what leads to the best outcomes in infants. And we also know that with prenatal substance exposure and with parents who have struggled with substance use, what we see is there's a higher risk for difficulties in this area. So we really want to make sure that regardless of the discipline that the person is, anyone who is going to interface with the family is going to have an approach that's going to support that relationship and that attachment. And so let's talk about the first area, and that is how can we actually structure the environment of the infant to actually help their regulation. So how can we decrease environmental stimulation? Again, we know that this is an area that's really hard for infants who have prenatal substance exposure, and that there are little things that we can do in their environment to really support them in their area. Infants who have prenatal substance exposure are trying to process what's happening in their environment, and that can be really hard for them. So we want to try to create an environment that minimizes what they need to process in the environment. So some simple things that you can do is reduce the noise level in the hospital or around the baby's bed. So, for example, reducing talking or unnecessary activity around the baby's bedside can really be helpful, because it's, again, limiting what the baby has to take in and process. Another thing that you can do is just using a soft, gentle voice when you're talking to the baby. So again, you're helping them process environmental stimuli and making it easier for them. So talking very slowly to them. And another very easy thing is turning off alarms as quickly as possible. Or is there alarms that don't necessarily need to be there, right? And can, again, because most times when an alarm comes off, it's going to startle the baby. And if they already have difficulties in self-regulation, that's going to lead to possible distress. So how can we kind of minimize what is going to startle the baby's attention so that they have less chances of being dysregulated? Another area is just reducing the light levels around the baby. Can you dim the lights? Can you minimize overhead lighting? Again, it's to help the baby process the environmental stimuli. Another area in terms of reducing environmental stimulation is using slow and gentle movements. So for example, when you're changing the baby's position, you want to do that slowly and without sudden jerky movements, right? You want to help them process what's happening to them, right? You might also want to gently touch them before you're going to change their position, so that you can cue them around, like, hey, I'm going to touch you right now, like, and now I'm going to move you. And you want to do that slowly. You want to use gentle handling whenever you have to either feed the baby, bathe the baby, or change the baby's diaper. You want to do that slowly. One of the natural inclinations we have is that if a newborn is distressed or crying, we want to speed it up because we want it to happen more quickly, right? It's not fun for little ones to cry, and we want to do our cares very quickly. But what we find is that actually makes it more distressed. So if the infant is getting distressed, you actually want to slow down what you're doing, because what the baby is saying is, I don't know what's happening and I need help processing what's happening right now. The other area that you could do is establish a primary nurse model of care for babies who have prenatal substance exposure, who are at risk for neonatal opioid withdrawal syndrome. So why that's important is that newborns really get to know their caregivers, right? Each one of us has a different temperature of our skin. Our skin feels differently. How we move is different. And newborns are processing that information. And so what happens is that if the baby has multiple caregivers, right? Multiple nurses taking care of them, each time there's a new nurse, that newborn is processing who that person is. And it's creating more demands for their regulation capacity, right? So multiple caregivers present additional self-regulation demands, and consistency in caregivers actually promote the infant's ability to regulate. So trying to minimize the number of staff that will be caring for the baby will help them actually be more regulated. Another piece of your care that you can do to support the newborn is to cluster your cares together. So for example, how do we try to minimize the handling of the newborn? And one of the things you can do is making sure, especially with little ones who have prenatal substance exposure, is you want to make sure that you prepare everything before you're gonna approach the baby, so that you're gonna minimize the amount of time that you're handling the baby, as well as kind of, the disruption of that care. It's also going to help you, again, kind of concentrate on, okay, not only what do I need to do, but how am I going to do it? So if you're prepared, then you can really approach the baby with this slow, gentle approach, right? Because you're not thinking about what you need to do, but you can focus on how is this for the baby. So again, using those slow, gentle movements, and also scheduling your cares as much as possible during a time where the baby is awake and alert. We want to minimize the amount of times that we have to wake up the baby, in order to change a diaper or to weigh the baby or so on. And so we want to cluster those when the baby is already awake. Now, when you're providing care for the newborn, you also want to give them extra support that you may not do with a healthy newborn. So for example, if you're weighing the baby, you may want to consider swaddling the baby and giving he or she a pacifier to kind of, again, give them extra support. If you're going to do more intrusive procedures, or you have a newborn who is really sensitive to being handled, then you may want to give them a sucrose pacifier to give them extra support around that. And again, when you're going to have any type of cares, you want to kind of look at the environment and how can I minimize stimulation in the environment while I'm doing this care, right? So the noise level again, the light level, how do I kind of try to create as calm as possible of an environment, because I know that this may be stressful for the newborn.
Peggy, I was thinking of some ways that a care team might plan for this type of reduction in stimulation in an inpatient setting, because we were talking about alarms and lights and how we don't have a lot of control over those things in an inpatient setting. But I think I would suggest that people consider if the baby needs to be on a continuous monitoring where there be more alarms going off. Maybe the baby could get vital signs every 3 hours, so they would be with cares, or even every 8, because most of these babies are very stable. So just considering whether you want that baby to be on continuous monitoring, or if you want to do periodic vital sign monitoring, can reduce a lot of this noise and handling stimulation for a baby. So those can be considerations that a care team could do for a baby.
That's helpful. And again, all these recommendations are gonna are things to consider, and then to make sure that it makes sense for your medical team, right? What does this individual child need? You know, these are things to think about. So, so we talked about just reducing the environmental stimuli around the baby. The other area is how do we actually promote and encourage self-regulation? We know from research in early childhood is that self-regulation is really, really important and will continue to support the child throughout their childhood as well as adulthood, right? And that it begins from the very beginning. And so when we're talking about self-regulation, the first thing we want to think about with newborns is to just consider how different the environment they're in from the environment they just came. So for example, during their pregnancy, right, the little one is contained, they're snuggled, right, it's warm, and all these, and now they're in an environment that's very different, right? Again, they're having to process that experience, right? And so there are certain things that we can do that can promote their self-regulation. The first one has to do with positioning. Positioning for newborns are really important, especially for newborns who have higher risk, right? Either because of prenatal substance exposure or, you know, what we see in the NICU in terms of infants who are born preterm. And so one of the things that we look at is, can you position the baby to encourage flexion of the hips and the knees, right? Again, this kind of, if we look back to the last slide, if we think about the prenatal environment, they're always in flexion, right? Their knees and their hips are bent, as well as kind of their, and so we want to have positions that actually support that. And so, excuse me for a second. So flexion of the hips and the knees. One of the things that's really important is, can we encourage them to bring their hands to midline or bring their hands to their face? I know with little ones, sometimes we have some discomfort with that because of scratching or so on. And so again, it's individualized to the baby you're caring for. But bring their hands to midline is something that's easy to do and can really support self-regulation and actually help calm them. If the baby is laying on their side, can you bring their head and their hips forward? So again, to promote that flexion. And so so again, position can really help in terms of self-regulation. When you're holding the baby, right, if you think of how we naturally hold babies, we also kind of naturally provide that flexion in your arms. And so how do you kind of support that kind of containment, hands to midline, and flex positioning, you know? You can give gentle pressure to the back of the head and bring the head forward. That can actually help. For little ones who are laying on their back and may not be able to be swaddled, what you can do is just bring their hands to their chest and just provide gentle kind of pressure. And these are all things you can teach and should teach the parents around that too, because it really will help them be successful around their ability to calm their babies, right? And so these are little things to kind of think about. These are images of little ones who are not in containing positioning, right? And so if you look at the top baby whose arms are splayed as well as his legs are splayed, right? He's clearly distressed, right? The same with the diaper change. The little one who's having his diaper change. If you look, he's splayed out, right? And these are not actually positioning that actually promote regulation. Versus a little one who's swaddled, right? Again, it's contained, flexed, and their hands are to midline. There are things you can do even while you're doing cares to promote more of those natural positioning. So just like we looked at that last little picture, swaddling can really be helpful with little ones who have difficulties with self-regulation. Again, how do you swaddle in a flexed position, either on the baby's back or on the baby's side? Again, it's individual to that baby. You want to monitor the baby's temperature. And so, for example, some babies may not tolerate that. But again, it's something to think about. As we talked about before when we were talking about clustering care, again, pacifier use is really important in helping families understand that, there's some families that feel uncomfortable about pacifier use, and kind of helping them understand that this can really help their child in terms of their regulation, especially if that's an area that's hard for them. So what we know from research is that rhythmic, non-nutritive sucking has been found to have a soothing effect on little ones and can help with state organization. So little ones will go through different kind of state of arousal, and that can help with kind of that happening more smoothly. It can also help decrease kind of uncoordinated motor movements and distress in newborns.
Peggy, when we're talking about pacifier use, pacifiers are discouraged in baby-friendly scenarios in hospitals because they would interfere with babies letting parents know when they're ready for breastfeeding. But I would encourage hospitals who are designated baby-friendly to put babies who have prenatal opiate exposure. They really fall outside of the strict criteria of baby-friendly recommendations. So it's all right to use pacifiers for these babies. You will not be going against baby-friendly criteria because they have another diagnosis. Now, still, all those baby-friendly teachings about skin-to-skin and encouraging breastfeeding are beautiful for these babies as well, but don't feel like you can't use a pacifier for these babies because your hospital is baby-friendly. It will not go against that criteria.
Yeah, and what we know from research, and you guys will see there's references for what we're talking about is that one of the intervention that has a lot of support is actually pacifier use with little ones who have prenatal opiate exposure. And so sometimes helping families understand that too, because if they're getting different, again, it's a family's choice naturally, but if they're getting different messages to kind of help them understand that this really helps with this child's particular regulation needs. What Heather was just talking about is that we want to promote skin-to-skin contact, right? We know that touch is really healing for little ones who have difficulties with regulation as well as prenatal opiate exposure. So how do we encourage skin-to-skin contact? How do we encourage firm, gentle, close holding, right, between either the parent and the child, family member? How do we encourage breastfeeding? And also what we know is how do we encourage if they're holding vertical rocking. What's interesting in research with prenatal opiate exposure is what has been found is that vertical rocking is really helpful, and horizontal rocking is actually increases symptoms of withdrawal. And so it's one thing to think about. It's something to do with the vestibular system, and that is easier for them to process, and that it actually encourages eye-to-eye contact as well. And so vertical rocking definitely above horizontal rocking. And the other piece around kind of encouraging self-regulation is just really kind of watching the baby, right? Decreasing levels of stimulation when you start seeing signs of distress, right? Because we want them to learn that as well. So promoting and protecting sleep is really important with little ones with prenatal opiate exposure. We talked about swaddling, but swaddling really helps to promote that sleep. And we also, again, want to think about the environment and how it can actually support sleep as well. As much as possible, when the child is sleeping, we want to avoid kind of handling them or kind of scheduling cares, if that's possible, because we really want to protect that. A lot of the healing and kind of brain development is happening during that sleep period. We want to reduce stimulation again, and if you have to wake up the baby, you want to do so gently. Again, kind of that gentle touch even before you start gently waking them up. You want to give them time to process the stimulation. With families, we want to encourage kind of caregiving activities that also promote sleep. So talk to families about the importance of skin-to-skin care, about how it actually helps the baby sleep. Close holding and swaddling, all those pieces we want to teach families to help their baby sleep, right? Both to help them and to help the baby. And so educating parents about the importance of sleep and caregiving activities that promote sleep. Another big area is feeding support that can be harder for little ones who have prenatal opiate exposure. So again, how do we kind of hold the baby and handle the baby really gently while they're feeding? We always have to remember that feeding is the most complex thing that a newborn does. It's one of the hardest things that we do. And what they're trying to process in terms of coordinating their swallow and the respiration and is really hard. And if they're already kind of challenged in that area, we want to try to give them the most kind of support to be successful, right? So being gentle. If you have to wake up the baby, be very, do so slowly. Reduce stimulation around feeding. So again, try to create a calm environment so that feeding will be more successful. Excuse me. And you also want to, as much as possible, schedule the baby's feeding based on the infant cues, right? When is the baby telling us that they're hungry and feeding them then?
I think it's really important when you're talking about looking at baby's cues to decide when feeding might be most helpful, most appropriate for a particular newborn, is to help parents understand that cue reading process as well. Yeah. And getting out of the idea that we feed on a schedule, that every baby feeds on the same schedule, and really thinking about who is this individual baby, how do we understand their cues, how can we help parents understand their cues, and then how do we adjust feeding based on all that information.
And so a practical application of that would be ordering that the feeds are nipple, ad lib, on demand, cue 1 to 4 hours. So you give the baby that flexibility, and then to also say per infant cues. So that could be how you could put the order in the computer or in their order set and discuss with the care team how that might be the optimal way to give flexibility to a baby's feeding schedule.
Definitely. And as you're doing that, it allows an opportunity to actually educate the parents as well around that, and teach them, teach them about feeding readiness cues too. Small and frequent feedings are better, and with frequent stopping and burping of the baby, so that we can really kind of help them in that area. What you also want to do is actually pause feeding frequently and to look for signs of stress while they're feeding. And if there are signs of stress, you want to actually take a break, because the baby may be growing tired. The baby may need kind of extra support in terms of positioning, or may need some help in terms of calming. And what we want to remember is that a stressed baby will not feed well, right? And will have kind of sequelae around that, right? So stopping frequently, kind of watching the baby, how is he or she doing, and how do we kind of pause and step back if they're showing any signs of stress around feeding. Feeding is really hard, and we want to remember that.
And since we know that opiate withdrawal syndrome for babies it has two really important manifestations around feeding. For one, babies are kind of hyperoral, And so it can be hard to tell if they just want to suck on something or if they're hungry. And so that messaging can be difficult to sort out. So there is a tendency a lot of times for babies to get overfed. So the bottle will just keep getting put back in the baby's mouth, and the baby will feed and feed and feed until their tummy's so full that they're having emesis, which they're already prone to anyways. There's probably babies are nauseated when they have opiate withdrawal. So this, I think, takes a real quiet, centered focus for the care team to really tune into babies' feeding needs.
It's also a great opportunity to talk to parents about how complex feeding is. Every time I've spoken with parents about the mechanism of feeding that happens in the face and with the respiratory system and with swallowing, a lot of parents just don't realize how complex and difficult and tiring it is for a baby. So to be able to take pauses, give the baby a break, do some burping, maybe some slow repositioning, and then return back to a small feed that's more frequent will help parents feel more successful when they go home too.
If you look at the picture just below, there's a little one who's being fed, and there's little things that you can see that they're doing that probably is helping the baby. And these are little changes to practice. For example, if you look, the baby's hands are at midline, and the person who's feeding the baby is actually providing some containment on those hands, right? As well as some containment in the back of the little one's head, which again, containment and positioning is big. I can wonder about, the baby is looking away, which can be helpful. So one of the things, if you have a little one who's very reactive to stimuli, is actually kind of facing away from to a wall that has not a lot of kind of stimulation, right? And so that you can help them kind of focus on feeding. There are little things to do that can actually help the baby be successful and can actually make your caring of the baby easier as well. So what we always want to do in terms of tailoring our intervention is really to encourage individualized care. We can talk about all these kind of recommendations, right? But we want to know, is this going to help for this particular baby, right? So who is this little baby, right? How do we get to know in this short period of time as much about this little girl or little boy that can help us understand how to tailor their care? What we know of little ones who have prenatal opiate with exposure is that, the symptoms that they may show different symptoms over time, right? Differently over time. So one baby who has opiate withdrawal is going to be different than another baby who has opiate withdrawal. They may have a different kind of pattern of symptoms, and their own pattern of symptoms might change over time as well, right? Which makes it complex and makes it, but we really want to understand what is their pattern. They also might have a different pattern of responses to stimulation, right? Some may be overreactive and some may be underreactive, right? Some may respond to stimulation by being very reactive and kind of jerky in their movements and so on, and some may completely shut down. We don't want either, right? And so we want to understand what is their pattern of responses. And also, little ones will have different regulation needs. Some strategies may work for one baby and may not work for another baby. So we want to spend some time observing the baby to get to know his or her pattern. This will be invaluable in terms of your relationship with parents too, because your knowledge in this area can really feel supportive to parents who are trying to understand their newborn who are showing maybe different behaviors than their other babies may have shown, or this may be a first-time parent as well. So one of the most important things that we can do in terms of providing intervention is really being mindful of the environment in which we are welcoming the parent and the baby. How do we create a supportive environment for that baby as well as for that family? So how do we create a non-judgmental and compassionate environment? What we know from research and what we know from clinical care is that there's high levels of guilt, shame, and insecurity in parents where their babies have prenatal substance exposure. And so not only are they coping with what is happening to their baby, but there's a very, very complex internal process that they are going through at the very same time.
Right.
And what we know is that people will show guilt, shame, and insecurity differently. And so how do we create an environment that allows them to participate and not add more to that guilt and that shame?
Mm-hmm.
What we also know from substance use research is that there's high levels of trauma, adverse childhood experiences, as well as high levels of mental health disorders that are associated with a history of substance use disorders, right? So if we keep that in our mind, we don't need to necessarily know what that particular parent has gone through, but we can have an assumption that they've gone through hard times, right?
Mm-hmm.
And how do we create an environment that will not disengage them? What we also know is the baby's distress that they're experiencing in the hospital, as well as some of the withdrawal syndrome that they're showing. And the hospital in itself may bring up past traumas in that parent. And what we know from a very basic level is that parents are more likely to participate and be successful in non-judgmental environments, right? And so at the very least, knowing that their level of success as well as the outcomes of that baby is really dependent on the environment that we create and allow them to participate. It's always important to remember that stress makes us forget what we know and also makes it harder to learn what we don't know. And so with a little one who has prenatal substance exposure, there's a lot of learning that has to happen, right? It's not easy to take care of them. It's not easy to try to figure out what helps them and what and their symptoms and so on. And we have to understand that stress, that hospitalization, even if we know that the baby is relatively healthy, is very stressful for a family. And that's going to make it harder for them to learn. It's going to make them harder for them to kind of access their capacity also at times.
I think it's really important with this particular point to point out that when there's parents that have had children without a history of substance use exposure, and then there's been a gap, and then a baby that was born with substance use exposure, that all of their kind of parenting patterns that they may have utilized with older children, they may be harder to access given the stress of having a baby with opiate exposure and withdrawal. And also for medical staff too, that a stressful day, a packed unit, a lack of sleep for a medical professional can make those day-to-day routines even more stressful. And then we forget the little things that make such a big difference.
So how do we actually create a supportive environment? And Karen will talk a lot about this in terms of her talk around infant mental health. But one of the things that is key is just being aware of your own reactions. I think that is the first step, you know, and what we know is caring for a baby who has prenatal opiate exposure or who has neonatal opiate withdrawal syndrome can be hard. And so so having reactions and feelings around that is normal and shouldn't be necessarily avoided. What's important is just to be aware of them and take the time to understand and regulate your feelings, right? So having those reactions, nothing wrong with it. It's just, it is what it is. But how are you actually able to be aware of it so that then you can be mindful of how you can approach a family, right? So the most important thing you can do is check in with yourself before you interact with the family. So that can be as simple as saying, what am I feeling and am I activated, right? And taking that brief pause has been shown to change how you're going to approach a family and to increase kind of, again, that supportive environment and the engagement in the family. Again, it's useful to remember certain things, right? So it's useful to remember that substance use is usually associated with an extensive history of trauma, and to keep that in mind, right? It helps to kind of build compassion. And parents are feeling many intense feelings about what is happening to their baby, including guilt, shame, insecurity, and either overt or even covert kind of blame from the environment really intensifies what they're already experiencing. And also to just remember, we know this from ourselves too, is that people cope with stress differently, right? And that and that one of the most important things that parents who have a history of substance use difficulties and their little ones have prenatal substance exposure is they are trying to determine how safe they are with you. So those first interactions that they're having, they are trying to figure out how safe you are with them and how safe they can be with you. And that will dictate how much they're going to actually engage in cares with you, how much they're going to ask you questions, how much they're going to lean on you for areas when they're struggling, because they're trying to figure out, is this a relationship that I feel safe in?
Right.
And if they don't, they'll shut down. So creating a supportive environment is really important for the last piece of the interventions we're going to talk about, which is encouraging parent-child attachment. Everything that we want to do, even if it's a short period of time during this hospital stay, is to encourage kind of a foundation around a strong parent-child relationship. There's little things that we can do to support that, which can continue afterwards. So one of the most important things is helping parents get to know and understand their babies. Again, babies and newborns who have prenatal substance exposure can show different behaviors that can be frightening and can be interpreted very differently, right? As a nurse, as a medical professional, you often have a lot more knowledge about newborn behavior that can really help parents kind of normalize some of the fears that they're experiencing, and also help them kind of interpret them appropriately, right? So one of the things that you can do is notice how a parent interacts with their baby. Are they over or under stimulating the baby, right? And how can you help them understand that in a kind, supportive way? What are they doing well? It's really important to highlight those little things that the parents are doing, that they're really doing well for the baby. And that can be really powerful in giving them a sense of confidence and capacity in terms of their ability to care for their baby. And what's harder for them? You know, how do you kind of notice what's harder for them and actually help support them, either by providing information that would really help them kind of make that easier, right? Or by actually asking them, can I help you with this, you know? So how do you help them learn their baby's cues? Ask them what they've noticed about their baby. Share what you've noticed about their baby. And explain to them what different cues are. Newborn behavior is really complex, right? And is not something that there's unfortunately a guidebook for parents, particularly newborns that have prenatal substance exposure. And you can be a really valuable ally for parents in understanding their child's behavior and what they're showing. And the last piece is just helping them interact with their baby. So for example, help them position their baby properly, right? That not only helps them learn how to care for their baby, but actually leads to more successful interaction, which then leads the baby the parent gaining that confidence to be more engaged, right? How do you highlight these little joyful moments that you notice with a baby, right? The first time that a baby's able to maintain eye contact, right? And that is looking at their parent, and how do you kind of protect that and kind of say, like, look what, I just saw that was beautiful, right? And that, how do you highlight when the parent notices and responds to their baby's cues appropriately, right? And say like, wow, I really noticed how you picked up that he was getting stressed. And I noticed how you stepped back a little bit and really helped him calm down. You know, all these little things are really, really impactful for parents. And what we know from doing follow-up care with families who have little ones with medical vulnerabilities, that those are the moments that are really powerful for them and stay with them after they leave the hospital.
Yeah, I think
as home visitors, that's what we hear.
Yeah, becomes part of a mom and a dad's birth story, how it was that they experienced interaction with other adults in the hospital, and how it was that other adults in the hospital, professionals, would talk about their baby, talk about their birth, and talk about their handling of their child. It's very much a story that is associated with labor and delivery that stays with families for a really long time.
In line with this, how do you help parents participate in their baby's care? So asking them from the get-go, again, if you take the assumption that this may be something that they have just normal fears around, right? Especially if their baby had regulatory difficulties, ask them what they feel comfortable doing. and ask them if they would like your help, and ask them in what areas would they like your help around, because that can really be powerful around building their skills so that they can leave the hospital with a set of like tangible skills to take care of their baby.
Mm-hmm.
Again, normalizing any fear, right? A crying baby, again, what I go back to the first kind of, one of the first things we talked about is that when a baby cries, the first thing that you want to do is usually let's quickly change that diaper, right? It's intuitive, it's normal, it's let's get this done, right? But by helping them say, like, actually, let's slow it down, you can teach them these pieces that are really going to help them in the long run.
Mm-hmm.
And normalize, like, this is stressful, I get it, you know? Help them feel successful in their attempts. And again, create this safe environment that encourages questions and requests for assistance. We want them to ask questions, right? Another easy way to encourage that attachment is to encourage physical contact between the parent and the baby. So skin-to-skin contact, gentle close holding, encouraging breastfeeding. If the baby, you know, for some reason can't be held, just helping them just learn how to put their hands to midline to the chest, right? And all these things can help kind of set that bond in place at the beginning. Again, it's useful to remember these little things, right? So research has shown us that trauma, substance use, mental health influences a mother's ability to read a baby's cues. What we know from research is that parents who have a history of trauma, who have a history of substance use difficulties, or who have a poor mental health, have a harder time reading a baby's cues and need more help around that, right? Yeah. What we also know is that parents with substance use difficulties often have not had healthy role models in their own childhood around parenting. And so if you keep that, again, you don't need to know the parent's history, but if you keep that as a possibility, it really helps you approach the parent differently. And the last piece we know from research is that mothers often struggle with their sense of confidence around caring for their baby in general, but particularly when there's prenatal substance use.
With the last point here about moms struggling with their sense of confidence around caring for their baby, in my professional background and working with all different kinds of parents, parents with and without substance use exposure, I think it's important to remember that parenting is experienced as one of the most judged things that we do, and then it's just extremely intensified when you have prenatal exposure. It's something we talk about in our program all the time, about how the group of patients in healthcare that are typically the most stigmatized are moms who have been using drugs during pregnancy, and keeping that in mind to be able to have a good provider-patient relationship with that mom while building her confidence and helping her read her baby's cues without the filter of the shame and guilt that she's bringing into that experience. It's really intense for moms without this history, and even more so with moms who come into the hospital with their babies with opiate exposure.
Now, lastly, when we're talking about interventions, right, what can you do in terms of little things that you can do in your practice that can really be impactful in terms of little ones who have prenatal opiate exposure? One of the last things and most important things that you can remember is how you are is just as important as what you do, right? And that how you are with a baby as well as with a parent is an intervention in itself. As a clinical psychologist, you know, we look at that a lot, right? The research shows most of kind of treatment outcomes are based on the relationship that someone has with a provider, right? Whether that's a medical provider, whether that's a nurse, whether that's a clinical psychologist, a social worker, that relationship and how that person is with them is just as important, if not more, of what they actually do. And so parents and babies will remember how you were with them as much as what you did, right? And that parents will remember, just like Karen was talking about, how comfortable they felt with you and how you helped them be their baby's parent. And so if you keep that in mind, there's a lot of things you can do. We spend a lot of times about these little things that you can do in your practice, But if you remember that the foundation is how do you approach this baby and how do you approach this family is the most important thing, that you know that you've already kind of helped impact the care for that newborn as well as for that parent. Any questions that come to mind, or Heather, what would you like to add?
I wanted to frame this talk in terms of our larger project, where we were talking about the 3 stages of care for these babies and sort of the 3 levels of care that we're hoping the hospitals in New Mexico can provide for babies. So we talked about the initial observation, identification of babies who have prenatal opiate exposure will be something that all of our hospitals will be doing. And then some hospitals will have the observation period where they'll keep the dyad in the community hospital and observe the baby and see if the baby needs treatment. And then the 3rd stage is the pharmacologic treatment of these babies. And I want to emphasize that these teaching pieces would fit into all 3 of those stages. So immediately after delivery, when we're still working on identification of prenatal opiate exposure, we'd still be using these techniques. During the observation period is a really vital period to employ a lot of these non-pharmacologic interventions to decrease the risk of needing treatment. And then also during the treatment stage, when a baby is inpatient and needing medication, all of these pieces will be really valuable. And then I was also thinking about when a practical way to try to reset the care team when there is stress from busy service or a challenging family dynamic. And I was thinking about just last week when I was on service that we had kind of an overwhelming busy day for a lot of different reasons, and I was having conflict with outside agencies, and I was very activated for other reasons, and so I needed to reset myself. And so actually what we did is the chairs in our unit are kind of tall, so most women are their legs don't touch their feet can't rest on the floor. So I went around to see if every mom needed a footrest, and I pulled the footrest out for the moms whose feet were hanging down. And it was just a way to reset and just think about mom's kind of comfort and to offer comfort in a stressful situation. So just thinking of maybe one small intervention that allows you to reset your activation in these settings can just help reframe your care for family. And so just thinking about mom's foot comfort was a way to kind of to just reset everything and kind of focus on the environment for the dyads in that setting.
We talk a lot about in our program and with our staff around what is, everyone has different things that they can do to reset themselves, and to self-regulate themselves. And one thing may work for another versus may not. And so actually getting to know what actually helps me. For some people, it may just be pausing. It may be saying something to themselves, like something that is meaningful. It could be just breathing. Sometimes it just might be taking a 5-minute break, but whatever it is, so that you know that you're approaching not only the next baby you care for, as well as the next parent that you care for in a regulated way, right? And so we're trying to help regulate the baby, we're trying to help regulate the parent, and we're also having to notice and to be aware of our own regulation in order to have that happen.
I think it's especially hard in the hospital because you go from baby to baby so quickly, and to be able to have something in your mind that shifts your thinking away from the baby you're walking away from and towards the baby you're going to go work with, that also allows for some sense of calm and organization and relaxation before you approach your next patient. And they're so tiny and they're right next to each other, and so how do we know ourselves well enough to go through that in the course of the day?
Well, thank you, Peggy.
Thank you.
Thanks, Karen.
Appreciate it. Thank you.
And thank you everyone today for these incredibly valuable contributions to our project. We appreciate it. And we hope you join us next time for our next presentation.